My name is Gregory Mathews. I'm a neurologist in Maryland, in the suburbs of Washington, D.C. I specialize in epilepsy. I've been in practice for 16 years outside of my training. I got involved in My Epilepsy Story through my initially professional relationship with Brandy as her neurologist, and subsequently as a person who was believed in her cause, felt very strongly that her ideas about bringing information to women and girls with epilepsy was extremely important. And the way that you do that is one person at a time. You make an impression one person at a time and change their life, and that's the way you go forward. I think my experience with Brandy illustrates a couple of points, and that is that you have to know the whole patient, you have to know what's going on in their life, you have to know their history, and know what your goals are. So Brandy had some concerns about a medication she was taking for her epilepsy, although it was working. She had had a outcome of a pregnancy that was of concern that it may have been due to her medication. And knowing that Brandy, or discussing with Brandy whether she wanted to have children in the future, and she said she did, and that's an important question that you need to ask right away with any woman with epilepsy, is that we decided we had to change her medication. Now, changing a medication isn't always easy. It's usually successful, but you have to know where the person is in their life, and that there's some risk to changing medications. There's some risk that the change causes either results in a seizure or adverse effects of the new medication, and you have to be ready for that. To be ready for that, you have to know what else is going on in their life. You have to know you have to set the expectations that this is potentially going to be disruptive. So you have to have a relationship with the person and know how to prepare them for changes. And you have to know that you're doing it for the right reason, so that the person is on board if there are any complications with the changeover. Coordination between the neurologist and the obstetrician is really quite simple. When I see a patient in my office, I make a copy of the office note to be sent to the obstetrician's office so that they know the patient's following with me and what we're doing. But I think it requires a little more than that, because I think there should be a phone conversation, a real conversation, just so that the two physicians know each other, know you're working together with the patient, know that there's a line of communication in case complications arise. You've talked to each other. You know there's a degree of personal knowledge. I've had a few patients who, when things got rough, for whatever reason during the pregnancy, the obstetrician knew that there was a neurologist at the other end who was also involved in this patient's care, and we both had a vested interest in a good outcome. And I think that makes a world of difference. And I think that a simple phone call early on in the pregnancy to say, hey, I'm another doctor involved in this patient's care. Let's talk to each other if we need to. I think that makes all the difference. Educating patients about their condition and about their medications is critical. I can't tell you how many patients, when I've gotten to know them, did not know the importance of taking their medication on time or taking their medication on a regular basis. Or the phone call from a patient saying, I'm pregnant, I've stopped all my medicines, can you call me back? And trying to get a hold of that person as soon as possible to explain to them that they shouldn't be stopping their medicines, they should be coming in and we talk about their medications. Being proactive, educating people about their condition right up front. Explain to them. I always, when I see a new patient, after I get their history, I always say to them, so let me tell you about epilepsy. What is epilepsy? And what is it about? What does it do? How do we treat it? And I say, you know, I know some of this you may know already, but some of it you may not. And then use it as a springboard for the patient to ask me questions. I encourage them to learn more about their condition. And from the physician's end, I encourage them to tell me about their experience with their condition, so I understand where they're coming from. When you have treatment failures, it's because oftentimes because people don't understand their condition. They're not taking their medicines correctly, or something like that. So if I've learned that early on, I know what my goals are. My goals aren't to find a better medicine. My goals are to teach the patient how to take their medicine, for example. And that can improve the outcome.